We're going to be talking about a very specific topic, but it's very relevant to folks who are in their 60s, specifically 65, and also folks who are disabled and or qualify for Social Security disability income. Very, very important discussion. It's Medicare. Why? Because health insurance is a critical need, critical planning need for people who are in the retirement years, or at least who are 65 plus. And Medicare is one of the best deals in the economic world. The cost of that coverage is so expensive, but the government pays just about everything, and it's a very important benefit, very cost effective. But it's also important to remember that Medicare has to fit with financial planning. So we always do everything in context with other things: investments, income planning, healthcare, covering risks, tax planning, estate planning. All that ties together to make sure that everything is planned the way it should be. So I'm going to introduce Brady Fitzgerald. Brady is a specialist on Medicare. He's a registered health underwriter, certified life underwriter. He's a fellow of the Life Management Institute. So he has a lot of credentials in our profession. But the way he's integrated with Dedicated Financial Services, he's part of an organization that we work with in providing full service to our clients. And Medicare is what he does. And what I'm going to do is preface some of the things he'll be talking about. At this time of the year, you hear a lot about different insurance coverages. You hear it all the time, all over the place. That's really for Medicare Advantage. That's for folks who want to change from the traditional Medicare to the Advantage plan. I actually happen to call it Medicare Disadvantage, just a little play on words I talk about. It's an HMO approach to Medicare. I prefer the traditional Medicare because it is the best coverage you can get. Couple criteria for me and how you know you have a good coverage is, first of all, you make your healthcare decisions. You decide which doctors you go to and when. You have unlimited benefits. And the last thing is that it's affordable. And that's really all the criteria for the Medicare plans. Medicare is a great coverage, has some holes in it. And Brady's going to talk about how to cover those holes with different plans. So Brady, I don't want to tie you up any further, just let you get into the conversation. And of course, if folks want to ask questions, we do ask that they put notes in their chat, so we can answer them as much as possible. I'll answer them, or Brady will answer them, but I want to have Brady run the meeting because Brady is one of the fellows that you'll be working with for folks who sign up working with us on Medicare more closely. All right, Brady, thanks so much for being part of our program tonight.
Yeah, thank you, Lynn. Thank you for that introduction. I did want to definitely say you can put your questions in the chat and we can monitor that. I don't know if that's something you guys can monitor on your end and we can just answer those at the end. I'd rather get through the presentation and then, as we go through, we can always go back to the presentation to where it might be pertinent for that question. How do you feel about that, Lynn? Does that work? Okay, awesome. So I'm going to claim the host here and I'm going to share my screen. I'm going to do a little Medicare 101. It just breaks down what traditional Medicare is. And kind of what Lynn was alluding to is the different types of coverage options available to us, because I don't want anybody to ever be exposed to traditional Medicare at all. So I know everybody's situation is a little bit different, and that's why it's important for, after we kind of do this little breakdown, for us to have a one-on-one conversation. I believe that you guys should be putting in the chat here, or I can put it in the chat, a link to Lynn's webpage with the Medicare tab where you can fill out a form. You fill out that form, it gets sent to them, it gets sent to me. I'll reach out via email or phone call to set up a time where we can do a Zoom call or a phone call to go into your specific situation. But we should be able to get that in chat. That way you guys have access to that as well if you have a one-off situation you want to talk to me about. I'm going to go ahead and share my screen here. Let me go back here. Lynn, are you able to see my screen? Can you give me a thumbs up if you can? Awesome. Okay. So once again, we're just going to do a quick little Medicare 101. Probably take us about 20 minutes. We'll have 10, 15 minutes for questions at the end. Really just going to break down what Medicare Part A and Part B are. That's what I call traditional Medicare. It's offered by the federal government. Part A is going to be often referred to as our hospital insurance, but it does more than just hospitalization coverage. It does skilled nursing facility, hospice, and home health care as well. That's going to be covered underneath that Part A umbrella. And then Part B is your quote unquote medical insurance that does doctor appointments, primary specialist, specialist, can't speak, any type of outpatient care, MRIs, CT scans, X-rays, is going to fall underneath outpatient care as well. Does occupational physical therapy, speech therapy, also does durable medical equipment, walkers, oxygen tanks, CPAP machines, going to fall under the Part B side as well. In addition to that, it does cover drugs that are administered in a doctor's office, like dialysis or chemotherapy, or if you take injections, infusions, or any sort of kind, they would be covered underneath the Part B umbrella. But this is traditional Medicare. Big caveat here I want you guys to really pay attention to is I'm only talking really anything medical. That's all traditional Medicare covers. If we have pharmaceutical drugs, we need to make sure we have drug coverage. There's two options that we can get that. We can kind of touch on that here later. But it doesn't cover drugs that you get at a pharmacy. It doesn't cover any dental, vision, or hearing. So we would want to make sure that we get that covered as well. That's something I can help facilitate. I got many carriers I work with when it comes to dental and vision. I also do cancer, heart attack, and stroke policies, long-term care, hospital indemnities, a bunch of things that we can always have a discussion about based off your situation. So really, this is traditional Medicare Part A and B. When I'm talking traditional, this is what I mean. Part C, I'm going to kind of skip over right now. I'll touch on it a little bit because I'm from the school of thought that Lynn is. Part C is Medicare Advantage. It's what's getting thrown down your throat 24/7 during this time period, all over the radio, all over the television, telling you to come get all the benefits you're entitled to. But it's the way I look at it, it's kind of a rug pull. It's not the most comprehensive coverage you can find. In certain situations, it does work for people. So I'm going to touch on it a little bit. But main focus here is at least looking at our options. And final option here is Part D, drug coverage. So we have to have that. Whether, we have, if you're military, you have VA or TRICARE coverage, that's credible coverage. You don't need a separate Part D plan. If you had a Medicare supplement or a Medigap policy, we would want to make sure you had a Part D drug coverage to go along with it to make sure that's covered. Or you can get it through a Medicare Advantage plan a lot of the times as well. So eligibility. This is one of the biggest common misconceptions about Medicare is, when am I supposed to take it? I'm supposed to take it when I'm eligible. We all kind of know that age is 65. So you are eligible for Medicare once you turn 65. There's an enrollment period. I have it on the next slide. It kind of tells you, gives us that window of when we need to sign up if we're supposed to at that time. Because a lot of the times, what I've come across, we're 65, but we're still working. We plan on working until 67, 68. And in that situation, we might not need to take Medicare if we have what Medicare will deem other credible coverage. So yes, we're eligible when we turn 65. Lynn already kind of alluded to it at the beginning. We do qualify if we're under 65 and have SSDI, Social Security Disability Insurance. That's for 24 consecutive months. On the 25th month, the Social Security will automatically put us on Medicare. So are certain situations if we're under 65 that we're Medicare eligible. There is automatic enrollment. So when we have a one-off conversation and you're trying to figure out the timing on everything, this is probably one of the first questions that I'm going to ask you is if you're already receiving Social Security. If you are already receiving Social Security before the age of 65, you will be automatically enrolled into Medicare Parts A and B. That might not be something that you want to do at that time because you may be still working. And depending on your situation and your current coverage, it might be more beneficial for you to stay with the employer coverage, or it might be beneficial to go with Medicare. That's why it's important to use the link that Lynn and the team should provide here in the chat to get to the web form, to fill that out, get on my calendar, and we'll discuss your current situation. This is that window I was talking about here. This is the initial enrollment period. It happens 3 months before the date of your 65th birthday. the month of your 65th birthday, and 3 months after your 65th birthday, you have the enrollment period to get into Medicare. Once again, it's a 7-month window, but if you retire after 65, if we talk and, your 65th birthday is coming up here in 5 months, but you say, Brady, I'm working till I'm 68. Do I need to take Medicare? You might not need to take Medicare at that time. So that's one of the biggest misconceptions I found is everybody thinks they need to take Medicare at 65 or unless they'll get hit with the penalty. Some people might, depending on their situation. Some people might not. And in that situation is if you are with an employer and you have coverage through that employer and that employer employs more than 20 employees, Medicare will deem that as credible coverage. So we wouldn't need to take Medicare until we were ready to retire or lost our employer coverage or whatever it may be after 65. So if you have any questions about that, put it in the chat, get on my calendar. I mean, like I said, everybody's situation is a little bit different. This is probably one of my favorite slides of this whole presentation because it really does break down the exposure that traditional Medicare leaves us exposed to. With the out-of-pocket costs and expenses that we could be on the hook for. So this is the cost for 2024. These numbers do change year in and year out for the Part A and Part B with deductibles and the premiums on the Part B side. It does change. It does go up and down, so it's not always a steady increase. It has gone up and down in years past, and if it does go up and down, it's nothing more than $10 or $15 either way that I've seen. Could change in the future, but well, over the past 5 years, it's been pretty steady if it's gone up or down. So once again, Part A, when I'm talking Medicare Part A, remember that's our hospital insurance, hospice, home health care, skilled nursing facility. It doesn't cost us anything. If we paid Medicare taxes, well, Social Security taxes for 10 years prior to taking Medicare Part A. And if you're worried about that, maybe you're a homemaker, the spouse, we lived off the one income, the spouse provided enough income. And you were a homemaker and you didn't work for at least 10 years, 40 quarters before taking Part A, you would qualify through your spouse. So once again, that's one of the biggest questions that pop up as well. Every situation is unique. So I definitely encourage people to get on my calendar. But most of the time, Part A doesn't cost us anything. So a lot of people that are still working and aren't ready to retire, they will take Part A. Just because it doesn't cost them anything, you might as well just get it out of the way. But it would be secondary to the employer coverage. It does have a deductible. It's $1,632 for 2024. And the big thing there to realize is that's per benefit period. That's not an annualized deductible. It's a benefit period. So a benefit period is 60 days in Medicare. So Lynn, you're on my screen. This is just if you had traditional Medicare, you got admitted to the hospital, you're going to pay $1,632 for room and board. You got discharged 2 days later, or you were in there for 2 days. You didn't pay anything extra for room and board because it covers up to 60 days in the hospital with no extra cost. You can see that there on the next part of this slide. But you get discharged and you come back 60 days later, you're going to pay that $1,632 deductible again. So if you time it right, you could really pay this 5-6 times in a year if you really time it right. God forbid that doesn't happen, but it does leave us exposed. That's quite a bit of money out of pocket for a deductible. Medicare covers up to 150 days in the hospital per year. That's kind of where long-term care insurance comes into play. If you're worried about that, that's something I can help look at as well. You can see here for the first 60 days in the hospital, we don't pay anything extra, but if we're in there for days 61 through 90, we're going to be $408 per day. 91 through 150, it's $816 per day in 2024. Skilled nursing facilities are kind of set up the same way. We're going to pay the deductible when we go in. First 20 days are covered. Days 21 through 100, which 100 is the Medicare approved amount, it would be $204 per day. Part B. So Part B does have a premium. How they factor that, I'll show it on the next slide, is Medicare is going to look at your tax returns from 2 years prior, and they're going to determine what your Part B premium is. So the IRS sends this information to Medicare every year, your tax returns, they look at it from 2 years prior, and they base your Part B premium off of that. It's always on a 2-year look back on that. So in 2024, they're going to look at 2022's tax returns. In 2025, they're going to look at 2023's tax returns. 2026, they're going to look at this or next year's tax returns. So it's always on a 2-year look back period. There is a Part B deductible. It's a lot smaller than the Part A. And another thing is it's an annualized deductible as well. So we pay our Part B premium. If we go to the doctors, the hospital, or anything like that, we won't really pay any co-payments. They'll just bill us. Will bill us up to the $240 deductible. And then once we satisfy that deductible, we're still on the hook for 20% because Medicare will take care of 80%. So the best way to describe that is, you know, if we had a $100,000 medical bill and we only had traditional Medicare, we're at least on the hook of $20,000 of that coming out of pocket. It's a lot of money. And that's why I will never, ever leave anybody exposed to traditional Medicare at all. Yes, we need to have it, but is the most basic coverage that you can have. Okay. This is about the Part B premium. So once again, we're looking at 2024. These numbers do change year in and year out as well. So I think this year, the Part B premium, the lowest bracket was $164.90. It went up to $174.70. Last year was $171. So it does go up and down $7, $10 per year. Not big changes, but it's something that I keep in mind when we have our conversation. Hey, what is this going to cost me? All things considered, we're able to kind of, hey, what's your ballpark number? Were you married? Are you guys married? Yes. You filed jointly? Yes. Okay. In 2022, what was your modified adjusted gross income if you had to ballpark it? If it's less than $206,000, your Part B premium will be $174.70. Now, this is the federal government we're working with here. So the more money we make, the more money they're going to get their hands on. So if you're in a different bracket here, your premium is going to be based off of that bracket that you're in. Now, if that situation was a one-off situation, there's forms that we can go out there and file an appeal for to try to get your Part B premiums lower. Maybe you did some conversions, stock conversions, sold off a bunch of assets, whatever it may be. There's, in 2022, maybe the income was higher because you sold your house, sold some assets, whatever it may be, but you don't have that normal income right now. Well, there's always a form we can go out there and try to appeal that decision with Medicare to get you in a lower bracket saying, hey, that's not the normal income. You guys are trying to base my Part B premiums off of this, but really it should be based off of this.
Great. Let me just jump in here. Mm-hmm. So a lot of people have a question about the modified adjusted gross income. Mm-hmm. Just think of that as your adjusted gross income. There's some technical differences between modified adjusted gross income and adjusted gross income. Let's not get caught up in that. Very, very few people are affected by that. So adjusted gross income, what does that include? It includes all your employment income. It will include your interest income. It will include your capital gains. It will include your pension. It will include your distributions from your IRAs. And if you have a fair amount of income, it will include 85% of your Social Security. So you add up all that, and this is before the deduction. This is your above the line. This is your income. And in 2024, is this 2024 to 103,000?
Yeah, if you're an individual in 2024 and filed individually in less than 103,000, your Part B premium would be 174.70.
So it's 2 years. So if you have more than 103,000 as a single of, let's just say, adjusted gross income or 206, so it's kind of at the top of the 22% tax bracket if you look at it that way, just roughly, right? And why is that important? Because you have to manage your income so that you don't exceed those amounts, because if you exceed that amount, you're going to be paying higher premiums, all right? And like Brady had mentioned, they go back 2 years prior. So if you're going to be 65 and you're going to qualify and apply for Medicare Part B in 2024, the income you're earning in 2025, 2 years later, is what is going to trigger that premium. So you have to be thinking ahead how you're generating income and how that's going to affect your premiums in the future.
100%. And I'm not that guy. Lynn's that guy to figure that out. So he'll be able to get that squared away. I can let you know what the premiums are, but that's his neck of the woods. So our different types of coverage options here. There's really one of three options. Option number one, if we're a federal employee or have a retirement option through our employer that they're going to offer for a lifetime. Everybody's situation is a little bit different. That's option one. We can discuss those when we have the one-on-one conversations. But on the Medicare side, there's really two options. There's getting a Medicare supplement policy, also known as a Medigap, plus a standalone drug plan, because Medigaps, they are excellent medical coverage. They really come in and pick up the slack where part A and B leave us exposed to, but that's all they really are. So we would need drug coverage. If we needed anything else, dental and vision, we would tack that on as well. Or you can go to the Medicare Advantage, or as Lynn put it, disadvantage. That's another option for us. A lot of the times those do include the drug coverage already in there, a few other bells and whistles, but they're very restrictive. They are going to nickel and dime you throughout the course of the year when you use the services. So, I'm going to kind of break down the differences. Everybody's situation is a little bit different. I understand that, but I'm from the school of thought. If we can afford the supplemental and give us that utmost flexibility and freedom to choose any doctor, any hospital, and it's excellent medical coverage, 10 times out of 10, we want to do that.
Brady, is this a good time to talk about the differences between Medicare, the traditional Medicare, and the Advantage, and why people may want one or the other, or do you want to do that later on in the program?
I'll do it a little bit later on. I got a slide that kind of breaks it down. Advantage and disadvantage of each one. So Medicare supplements, also known as Medigap policies, once again, excellent medical coverage. What's cool here is that they are standardized by Medicare. So Medicare is alphabet soup. We've already talked traditional Medicare, which is part A and part B, and then there's part D, which is drug coverage. But when we talk supplements and Medigap policies, there's a bunch of different plan letters as well. So there's plan A, plan B, plan C, plan D, G, K, L, M, and N. So a lot of different letters there when it comes to the plans. I will say 99.9% of the plans I do write are a plan G on Medicare supplements. What's nice about that is I work with 30 to 35 different carriers. Every plan G is the exact same. Okay, so it doesn't matter if it's a all-state supplemental plan G, if it's a United Healthcare, Aetna, Lumico, ACE, Mutual of Omaha. The list goes on and on. They are all the exact same. They all only leave us exposed to whatever it leaves us exposed to, depending on that plan letter. They're required to do so. Now, they do have the ability to charge different premiums. So there's a caveat there. So even though it's the exact same coverage, they can charge us different premiums. So this is a point in time where I really like to talk about if we already are on Medicare and maybe we have a supplemental plan G or a plan F and we've had it for 5 or 6 years. And when it started out, it was great. We had a low premium, but we've had some rate increases over the years. And, we feel like we might be overpaying. We can always reshop those. We can always see if we can get a better rate for the same exact coverage, because it doesn't matter the carrier. Your doctor will accept you. Your hospital will accept you anywhere in the United States if you have a supplemental plan. So there's no networks at all. You can go to any doctor, any hospital. If they accept traditional Medicare, which is about 98.5% of all doctors last time I checked, and hospitals, they will accept that supplemental regardless of the carrier. How that works is, say you go to the hospital, they take your Medicare card, it's Medicare approved, you got a surgery and it's Medicare approved. Medicare will look at it, they'll take care of their portion, they'll send it off to your supplemental carrier. I don't care if it's one of those carriers I've already listed. Your carrier goes, Medicare approved it, we're required to approve it. We have to, because the Medicare approved it. And then if you haven't, depending on what your plan may leave you exposed to, depending on your plan letter, you might have co-insurance, deductible, or anything like that. I'm going to go here on the next slide and kind of let you know. Like I said, 99.9% of the plans I write are a plan G. It's right there. It's smack dab in the middle. This is how it supplements. That's where it gets its name from. It supplements Medicare Part A and B. You can kind of see here, it picks up 100% of everything, minus the Part B deductible. So an illustration of that on the next slide here. So this is going back to our original Medicare. Remember, it leaves us way too exposed. We have deductibles. We have that 20% co-insurance. And that, I mean, that's a lot of money out of pocket if we have a bad medical year. If we had a Medicare supplemental plan G, depending on your neck of the woods, I mean, Lynn, I just worked with one of your clients earlier today. Looked at a supplemental plan. It was $140, $145 a month. So each zip code is a little bit different on the pricing, but you know, it's going to have a premium. But what that supplemental plan G does, it comes in and takes away that Part A deductible. You got a question, Lynn?
No, when you finish the thought, I wanted to just wrap something up.
Okay. Yeah. Part A deductible takes care of that. It's going to take away all of our hospital stay co-payments up to the Medicare approved amount. Same way with the skilled nursing facility. It's going to take away that 20% that Medicare leaves us on the hook for after the Part B deductible. So you can see here, the Medicare Supplemental Plan G, we're still going to pay a premium for the Plan G. We're going to pay our Part B premium. We have to. But the only thing we're exposed to for at least 2024 is only $240. So if that happened, say you had a slip and fall in January, went to the hospital, you're not going to pay any co-payments or anything. Medicare is going to approve it. They'll send it to your carrier. If you haven't hit that $240 deductible yet, they'll send you a bill. Even if that bill is $100,000, the most that they can bill you for is $240. Say that's January 1, you've already satisfied that deductible. So for the rest of the year, you are picked up at 100%. It is excellent, excellent medical coverage.
I just want to give a little perspective here. So when you look at the Medicare coverage, it's very, very good, but you'll notice there's a few things it doesn't pay. It doesn't pay a deductible. It doesn't pay hospital co-pays after a certain number of stays. It has a deductible for Part B. It has a 20% co-payment for Part B for doctor's bills. And so what happens is you have these individual holes in the coverage, and then you have the different plans that fill different parts of those holes. It's kind of like a puzzle. And you look at the puzzle, and I don't know if this may be a good time to go back to the other slide and look at the different plans, and you'll see the different plans cover the different holes. So you look at which holes do you want to cover, and which plans cover those holes. And what Brady was saying, you almost always will select a Plan G. Almost always will select a Plan G because it covers all the holes. The only thing it doesn't cover is the Medicare Part B deductible. That's the only thing you're out of pocket. Now you could save a premium and say, you know what? I'm not worried about the Medicare Part B access charges. The Medicare Part B access charges is when doctors charge more than Medicare allows. So,
15% on that.
So this allows, doctors who are the higher end doctors, so that plan and covers that. And then you see other plans, there's certain things that they won't cover. And the perspective is, listen, if you could afford the premium, then get the best coverage. Because one other thing that I think Brady will probably talk about is you don't have an unlimited choice to go to any one of these supplements anytime you want. There are certain opportunities to go in a certain supplement, and you can't upscale to better plans. So the idea is get the best plan you can with the best carrier, because you want to make sure that you are going to have that plan for your entire life, and you feel comfortable with that carrier, that they'll be around, and you don't have to be shopping for another carrier and may have limitations in who will take your coverage in the future. So I don't know if you want to talk also about the pre-existing conditions, Brady.
Right. Yep. That was on the next slide I was going to get to. Thank you for that, Lynn. So what he's alluding to there is, as we get into Medicare and our Part B starts, whether, we take it at 65 or if we're retiring at 68, we decide to take Part B, then we have what they call an open enrollment period to get a Medicare supplement. It lasts 6 months after your Part B goes into effect. Obviously, I would want it taken care of the day the Part B goes into effect. That way we're not exposed to the traditional Medicare at all. But what that open enrollment period is, it's a guaranteed issue window where, regardless of any pre-existing condition or your health status or anything like that, they have to accept you when you get on Medicare. When that Part B goes into effect, excuse me. Yeah, that 6 month window, once again, I want it done day one. But I mean, if we have a history of cancer or heart attacks or strokes, major surgeries, anything like that, ALS, Parkinson's, dementia, whatever it may be, diabetes, they, regardless of your health status, they're going to take you. Okay. Our only other window outside of that. So say we went with the Medicare supplement. Len, you started it when you took your Part B. We tried to get you the best rate, best carrier at the time. 8 years, 9 years down the road, it's gone up. I mean, it's health insurance. It is going to go up as we get older. We're more of a risk. We're more of a liability. It is what it is. But we're just not comfortable with the premium. We can go out there and reshop them 100%. We can, but we would need a past medical underwriting. So if you do have any conditions, like some carriers are a little bit lenient than others. Cigna is a big one that will take diabetic patients and no problem. Where a lot of the carriers will say, hey, you take insulin, we're not going to take you. Okay. So we can always reshop if we're in a, pretty good health and we're not, taking 5 different blood pressure medications. And once again, everybody's situation is a little bit different. We can always reevaluate these at any time. But it is, like Lynn's, it is important to get when our Part B goes into effect, because they're not going to ask any questions at that time. A lot of people say, well, I'm in good health right now. And this is kind of jumping ahead, Medicare Advantage, a lot of those plans don't have a monthly premium. You go, I'm going to save money and not pay premiums. I'm in good health, whatever. That is the case, but we don't buy insurance for today. We buy it for tomorrow and the future, right? Because we don't know what's going to happen. So yeah, we're healthy today. You take a Medicare Advantage, a year and a half down the road, you get diagnosed with cancer. You spent, I don't know, depending on the plan, maybe the out-of-pocket's $9,000 before you were finally picked up at 100%. Spent $9,000 and you were paying 20% for every chemo treatment that you got. You go, man, I really wish I had one of those plans where I just paid $140 a month and I only paid $240 in medical expenses. Most likely are not going to be able to get it with a cancer diagnosis. So that's why it's very important for us to, really nail home of all our options. And I don't want to say think about it, but if we're starting Medicare, now's the time to get the supplement, right, Lynn? We want to make sure we have that coverage in place.
Yeah, for my clients, as a fiduciary, I'm always Part G. If you can't afford it, there's another conversation. We'll talk about the Medicare Advantage plan and what is good about it and what is lacking. And here you go. That's it up for you, brother. There you go.
Yeah. So, I kind of just skipped ahead here. Medicare Advantage, it's pretty cut and dry. And this is how it compares to a Medicare supplement. So Medicare Advantage, a lot of the time they are $0 monthly premium or very low premium. So we don't really pay up front. It does include the drug coverage and the dental and vision a lot of the times as well, but they're going to nickel and dime you on the back end. We're going to have co-payments every time we use that plan. Depending on that plan, the co-payments are going to be dependent on the plan. So unlike Medicare supplements, they're not standardized. So you could have 4 or 5 different Humana plans in your area, and they're all different from the others. Primary could be anywhere from $0 to $30. Specialist could be anywhere from $25 to $60. Hospitalizations could be $250 per day for the first 6 days, or it could be $500 per day for the first 4 days. It really depends on that plan. You could be exposed up to $10,000 in out-of-pocket costs before the plan would finally pick up at 100%. And another big thing here as well is it's going to be very restrictive. So it's going to restrict you to a network of doctors and hospitals. Where on the supplement side, if that doctor or hospital accepts traditional Medicare, they have to take that supplement regardless of the carrier. On Medicare Advantage, they can say, hey, I only contract with Humana. I don't do United Healthcare. I didn't like the way they handled the billing. And say, you were already on a United Healthcare plan and they accepted it that year, your doctor can say, I'm not accepting it next year. So that puts you in the position where you either need to go change your plan or change your doctor. Just a lot of headaches and hoops and hurdles to go through with Medicare Advantage. You're not going to have the ability to appeal coverage decisions with Medicare. So with the supplement, remember, if traditional Medicare accepts the claim, they say it's Medicare approved, that supplement's accepting the claim. Medicare Advantage, they can say, hey, I know traditional Medicare says this is approved, but we don't approve this. We're not going to do this. That's a hiccup as well. You might need referrals to go see a specialist. That kind of puts a pain in the process of expediting your healthcare. You're not going to have the ability to travel to use any doctor to any hospital in the United States with Medicare Advantage. So that's, once again, I'm from the school of thought with Lynn. If we can do the Medicare supplement, do it 10 times out of 10.
Let me talk a little bit why people will select Medicare, because I want to be very, very balanced about it. Sure, not paying a premium for some folks makes a difference, right? Because if you're saving someplace around $160 a month, you're talking a couple $1,000s a year savings. So you'll save a couple $1,000s if you don't have large medical expenses. If you have large medical expenses, you could have $8,000 out of pocket. So there goes all your savings. But for me, I said it earlier in the onset, for me, the definition of a good plan is you decide which doctors you go to and when. Medicare Advantage can restrict that. You may have to go to the primary care doctor, and before you go to a specialist, you have to go for physical therapy, or that whole rope. I think we've all been through that. You travel, you go out of state, you go on the West Coast or wherever you travel. Different plans will have different restrictions, which doctors you can go to when you're out there. So sure, it saves money. Also, the Medicare Advantage plans, they'll throw in some goodies like gym membership or eyeglass benefits or dental visits. And those are nice benefits, and they're worth maybe a few $100s a year, maybe a few $1,000s a year. But for me, let's think about what the game plan here is. The game plan is to get the best care if you need in a life-threatening situation. If I'm having a life-threatening situation, I want to have the ability to go to Penn, or I want to go to the Mayo Clinic, or I want to go to Houston Heart or Sloan Kettering, Johns Hopkins. I don't want the insurance company telling me, no, that's not a plan. We have a local doctor. I don't want that. So that's what I suggest to my clients. If you can afford it, get the best plan. Don't horse around with healthcare coverage. That's not where you want to save a few bucks.
No, 100%. Yeah. And just a backtrack on that and back you up on that. I know for a fact, Mayo Clinic doesn't accept any Medicare Advantage plans at all. They accept Medicare, which means they would accept the supplements, but they don't do any type of Medicare Advantage. So, that's really next section here. It's Part D, prescription drug coverage. That kind of changes year in and year out. We do need to make sure that we have drug coverage. If we do go the supplemental route, once again, it's excellent medical coverage, but it doesn't cover any pharmaceutical drugs. So we would need to make sure we have a Part D drug plan in place just to make sure, because if we don't have credible drug coverage, Medicare will penalize us for a lifetime. It doesn't go away. So it's 1% of the national average for every month that you're uncovered for Part D once your Part B goes into effect. I know I'm throwing a lot of letters out there, but case in point, we need to have credible drug coverage. So if we have a supplemental plan and I go, hey, Lynn, are you taking any prescriptions? No, Brady, I'm not. Okay, well, Lynn, just to avoid us from getting that Part D penalty, I'm just going to slap on the cheapest drug plan available. That way, and for this year, I've seen drug plans as low as $0. So we just want to make sure we are avoiding that penalty because it's a lifetime. It doesn't go away. That's pretty much everything that I wanted to touch base on. I know there's some questions in the Q&A. I want to get to them. But also I believe, was it in the chat? If everybody's able to open up the chat, they did put the link in there for the Medicare landing page. Go out there, fill out that form, because I know everybody's situation is a little bit different. And I definitely want to have a conversation with you. Hey, here's our options. What's your situation? Where do we go from here? I'm here to help assist with that whole process. Lynn, if you want to jump in here before I answer these questions, go for it.
Yes, I want to talk about Medicare Part D. And unlike the supplemental plans, we have the letters, Plan G is Plan G. Plan N is Plan N, no matter which carrier. Medicare Part D is a tangled mess. It is a disaster area. It's a classic example of the government offering benefits but making it impossible to understand. And what I mean by that is every plan handles drugs differently. And when I say different, it's like the wild, wild west. Some plans, they'll have different formularies. They'll have different plans covered on different copays. You have the generic, you have the brand, you have the specialty products. Then you have some plans you can't get this medication until you try this one, which you can't get until you try this one. And then you have the donut hole, and it is a mess. It is almost impossible to understand. So with the Medicare Part D, it's very, very important to talk to Brady. And when you talk to him, you have to let him know which prescription drugs you cover and which pharmacies you use, because that's another thing. Different pharmacies will have different arrangements with different plans. What I'm trying to say with this is Medicare Part D is very, very confusing. And what the job of Brady is to do is to look at which drugs do you use, which pharmacies do you use, how often you take these drugs, and based on your usage, what's the best combination of premium and out of pocket with the plan. I'll also mention this. Prescription drugs is really where there's the biggest differentiator between retiree plans and Medicare. That's where I see is the biggest difference. So for folks who have a good retirement plan, the prescription drugs would be the primary reason why you may want to keep that plan. Prescription drugs under Part D, you have limitations, you have certain maximums they pay. And if you have a really good employer-sponsored plan you can keep as a retiree, often it's worth it because of the prescriptions. But again, it's something you have to look at your specific situation and talk to Brady about that.
100%. Yeah. And like I said, to piggyback on what you just said, Part D is a mess. That's why I didn't want to get too deep into it with the donut hole and everything, because everybody's situation is a little bit different. That's why I encourage everybody to use the form, get on my calendar. Let's have a conversation. But I do know in 2025, the federal government's finally done something to kind of help alleviate the pricing with Part D and the out-of-pocket expenses. So I'm going to go ahead.
But you also talk about the open enrollment for prescription drugs, how you can always make that change. So
right,
if you don't get it right this year, talk a little bit about that, please.
Yeah. So it's the annual enrollment period right now. It's between October 15th and December 7th of each year. It's the busiest time of the year for me. That's for people that have a supplemental plan with a standalone drug plan to change their drug plan for the upcoming year. So if we do already have drug coverage, and it was the most cost effective for us, like Lynn alluded to, between the actual plan premium and the cost of our drugs when we go get them, it worked great for 2023. But these drug plans, they change year in and year out, and I mean drastically. So we always want to reevaluate our drug plans for the upcoming year. Between October 15th and December 7th is that time period to do so. The new plans get released to me, agents and brokers, October 1st, and we can start enrolling people into those starting October 15th until December 7th at midnight. Once that hits, once December 8th hits, it's cut off.
Also, our medical need changes, right? How often do we go and we have this new condition and we have a medication that costs $400 a month? Okay, great. So we need to reassess the plan at that time.
Correct.
Question and answers. Let's do that.
Okay. Yeah. So I was just kind of pulling this up here. Does Advantage have a letter designation? It's Part C. It's on the traditional Medicare. It's Part C. There's no letter designation with Medicare Advantage. There's multiple carriers out there. There's Humana, Cigna, WellCare, Aetna, Anthem Blue Cross. That's just to name a few. And like I said, each one of those plans are a little bit different. So they're not standardized. So there could be 4 or 5 different Humana plans in your zip code, 4 different Anthem Blue Cross, 2 different United Healthcare. Or if you're in a zip code that's very rural, it could be very limited. You might not have that many options.
I want to just address a couple of questions I see here. Can you email a copy of the slides to us?
I can't. Do you want me to email it to you, Lynn, and then you send it out?
It's a question. Some people ask that. I don't know what's compliance approved. Maybe
it's compliance approved on our end. Yeah. I can send that out, no problem. I mean, a lot of the times when I do a Zoom 101 like this for initial meeting, I send the Zoom recording out and the slides for reference. So, yeah, I have no problem doing that.
We'll do that. Also, some people are asking about the how to sign up for a phone call. Oh, it's in the chat area, but I'll just mention www.dedicatedfinancialservices.com/Medicare. So it's just our company name, www.dedicatedfinancialservices, S at the end.com/Medicare. And on that page, it'll ask you some personal questions related to Medicare coverage. And there also will be a section you can put comments. So if you have a comment you want to make about your medical situation or about your overall financial situation, that will be a way to get that to me so I can address that related to things outside of maybe specifically Medicare. Okay. But that's specifically Medicare related questions that will go to Brady. So when you speak to him, he'll know that background to be better able to help you.
100%. John put in the Q&A chat here, is the payment amount of a supplemental plan based on Medicare allowance, meaning is the total amount paid to a hospital or physician limited in aggregate to Medicare's allowance. So every plan G is going to be what every other plan G is, regardless of the carrier. They are standardized, but when it comes to the premium amounts, there's 3 different ratings. There's community rated, which is they look at the geographical area. If say the United Healthcare Supplemental Plan G is community rated, they got a lot of people in the community on United Healthcare, but a lot of those people filed a lot of claims with them that year. They're going to boost the rate for everybody in the community. Another option is attained age as well, where they base your premium off the age that you get that policy, and will have steady rate increases depending as you get older. I mean, the rates are going to go up. So when I do recommend a supplemental plan, there's a lot that kind of goes into it. I want something that's in the market for a while. I want something that's stability and it has some backing where I can look at some market analytics to see, there is rate increases, but what kind of rate increases are we talking? Are they minimal? Are they huge spikes? Because I want something that's pretty consistent. I want something that's A-rated or above, meaning that, they do file the claims in a timely fashion. They have good customer service. So not only am I looking to get a cheaper premium, but I also want a carrier that you're going to stick with and that's going to do well by you. And that's not going to just throw you through hoops and hurdles with rate increases year in and year out as well. Rita put Part B, you mentioned occupational physical therapy and outpatient care. Does that include mental health care, chiropractic? Mental health care, yes. Chiropractic is a little bit, if it's medically necessary, yes. If it's medically necessary, it will be covered. But if you're going in there just to do a routine adjustment, most of the time it's not covered. But so once again, with supplements, every plan G is required to pay, only leave us exposed to that Part B deductible, $240. But there's a certain carriers that go out there and go a little bit above and beyond, where they'll have like a little bit of a wellness extra, where they might have some chiropractic coverage, maybe a gym membership through Silver Sneakers. United Healthcare is a big one like that. So once again, that's a situation that we can talk about if you get on my calendar.
I should notice there's a person on this call that is a physical therapist, and the physical therapy firm she works with does not cover Medicare Advantage. And this is amazing. The owner of the firm has decided the low reimbursement was actually costing her money. So if you have anything out of the ordinary, you're making a mistake for Medicare Advantage. If you have a chiropractor, you don't even know if it's going to be covered on Medicare Advantage. So just trust me on that area. If you can afford Plan G, you want Plan G, in the story.
100%. Yeah. And I think there was one above that. How does hospital stay coverage between Medicare and Advantage after 60 or 90 days? Medicare Advantage, it really depends on the plan. Remember, it could be $400 per day for the first 5 days, then you're finally picked up at 100%, but that's still $2,000 out of pocket. And then, of course, if you have an MRI in there, you're going to have an MRI copayment. If you do a CT scan or if you have a surgery, you're going to have copayments for that as well. That's really just for your room and board. Where supplements, you're not going to pay anything while you're in there. You're not going to have any copayments. And if you've already satisfied that deductible, say you got a plan G and you already satisfied that $240 deductible, that hospital stay is picked up at 100%.
If you're going to be in the hospital for 60 to 90 days with the Advantage, I can't imagine that you would not pay your maximum out of pocket. That for me is unimaginable.
You're going to 100%.
So what is it for? You know what it's going to be for 2024? Ray, I don't have that data. What's going to be the maximum out of pocket for the Medicare Advantage plans, either this year or next year?
It really depends on the zip code, really, because every plan is a little bit different. Medicare Advantage is really strong in the state of California. A lot of those plans are only $1,200 out of pocket. In your guys' neck of the wood, we're probably
8 to 10,000. It's probably going to be 8 to 10,000 is what I look at it for last year with some of the local carriers. So, to answer your question, hospital stay. If you have a strong Medicare Advantage plan, it's going to basically cost you nothing. I'm sorry, if you have a traditional Medicare Supplement plan, it will cost you nothing. Medicare Advantage, figure 8 to 10,000.
Correct. Kurt put in there, and Kurt, I didn't mean to skip over your question. I did see it a little bit earlier. Trying to put this back in the chat here, bring it a little bit lower. Did that go through? Hopefully you guys are able to click on the link. That's a link Lynn was referring to. It'll take you right to this page. And then there will be, what is it, down here, a little bit lower. Here's the form that you'll fill out. Just go in there and there'll be a couple other questions on the next slide, and that gets sent to them, gets sent to me. I reach out, we get on my calendar, and we discuss your situation. Kurt, it really depends on the retirement benefits available through the federal employee, really. Like I said, everybody's situation is a little bit different, and it's going to be what does that retirement plan offer you? When in terms of coverage, do we have deductibles? How much is it going to cost us per month? What's our drug coverage look like on it? I mean, what's all entailed into that? And then we can go, okay, side by side, apples to apples. Supplemental plan G only has the $240 deductible. We pay this monthly. Our drug plan costs us this. Compare that to the federal employee plan. Maybe it's $1,000 deductible, $2,000 deductible. We pay X amount per month. It's just something that we'll have to compare apples to apples. I will say this, though, with employee retirement, federal retirement benefits, if we get off of it and go Medicare, we can't go to the federal retirement benefit again. So that's something that we really definitely need to have a conversation with and consider.
Like I mentioned, the prescription drugs is really the cherry in that thing. Prescription drug, I don't want to get into the politics of it, but wouldn't it be nice if they just had a Part D that you can understand and it was just like easy to use? So it's prescription drugs, Kurt, is really the very, very important benefit with the federal plans and employer sponsor plans, definitely.
Right. I don't think I see any more questions at all.
We want to limit our program to about an hour, so we have a few more minutes. We don't want to tie people up, but we just wanted to make sure there aren't any questions. And I think just as a recap, I think you just really need to be intentional about all financial decisions you make, and specifically about Medicare. Medicare is a big decision because depending on what you decide when you're 65 might determine the health insurance coverage you're going to have for the rest of your life. Just use that as a thought process. What I select at age 65 might be the coverage I have for the rest of my life. That's an important decision. So that's why I really encourage our clients and just anyone I talk to opt for the best plan you can if you can afford it. If you can't afford it, then that's another story. Then you have to be, maybe you have to do the Medicare Advantage plan. There are some good Medicare Advantage plans in our area. So I don't want to say it's terrible coverage, but you have limitations. And sometimes in life, you get what you can afford. But if you can't pay that couple $100 premium for a good Medicare supplement plan, and also the Part D, you want to do that. Also, be important to know on the Part B premium, you're going to pay that whether you have a supplemental plan or the Advantage plan. You're going to have that. Now, what happens is when you're a consumer and you sign up for the Part B, Medicare takes your premium and they unload your risk to the local HMO, and they pay you, and Medicare is out. So in a lot of ways, quite frankly, Medicare would really like you to be on the HMO plan because you're not their liability. That's kind of the way it works. When you go with the Medicare Advantage plan, you don't have Medicare anymore. You don't have the Medicare structure, unlimited doctor base. You don't have that anymore. You're electing that HMO. And once you go that direction, you might not be able to come back.
Right. Right. Is there a donut hole closing schedule, Jerry? I'm not sure what you mean by that, the closing schedule, but there is a donut hole with Part D prescription drug coverage. How they factor that is every year the numbers get updated, and it's really, the plan pays X amount of dollars, retail costs, and you pay co-payments. Once the plan pays that X amount of dollars, they're going to charge you more for the drugs until you hit the catastrophic coverage, and that's another X amount. And so without getting too far in the weeds and really racking all of our brains, if you have specific questions, already on Medicare, and hey, I've been in the donut hole before, is there a plan that keeps me out of the donut hole or anything like that? Use that link, get on my calendar. We'll update everything. And if there's anything I can do, I'd be more than happy to.
Yeah, that question cannot be answered on a group call. It's not possible to answer that question. Just can't answer. It's just like saying, hey, I want a car. Like how much is it going to cost to fix my car? No idea what to tell you about that, right? Really, I'm being serious. It's a similar kind of a question.
Not to be rude, but I'll finish up with this one. So I always get asked this one. Not to be rude, but who pays you guys? Do you work for Medicare or question mark? My service to you is at no cost. So this is, once again, Lynn, I'm an Advisors Excel. He uses our services for a lot of things in the aspect of his business. One thing that he wanted to make sure that his clients were taken care of were the health side of things, because it's, we've already hammered home on it. It's a big part of financial planning for the future. So he doesn't pay me anything. You don't pay me anything. I get paid by my company, and I get paid by the carriers. So another thing here is, I've been asked this question as well. Do carriers pay me differently? No. It's a standard across the board. Each carrier pays me the exact same. So I'm not biased. I'm not incentivized to get you with a certain plan or certain carrier. My bottom line is to make sure that you're in a plan that you're comfortable with, that you can afford, and that's going to do right by you, regardless of my paycheck. It does my paycheck doesn't matter to me. I mean, it does, but not at your expense. I'm going to do what's best for you in your situation.
Also, people ask me, Len, why don't you handle this yourself? Because I provide full financial planning, and between November and December, I can't shut down my practice to do prescription drug analysis. I can't do that. I've clients that are relying on me to give them advice on tax planning toward the end of the year. We spend a lot of time on tax planning. I do prescription drug analysis. I can't do that. I can't get involved in all those details toward the end of the year, and it's very time consuming. I want to spend my time helping clients with the big financial decisions related to what they're doing with their life and how the money is structured to meet their needs. So that people ask me that as well. So that's why I use Brady and the team he works with to provide an extension of what we do.
Awesome. Yeah. But yeah, that kind of takes up my time. There is one last one, Jerry. So yeah, he did reiterate. I thought Medicare was closing the hole over time. yes, in 2025, I kind of already talked about it. There are going to be some major changes to the actual the drug side of Medicare. Like I said, our federal government's finally did something long overdue. They are closing that gap. There's no more donut hole in 2025. They're going to limit the max out of pocket on what we pay for our drugs. So there's been in legislation for a while, but I mean, that's still a year out.
But it does not affect us this year. We still have to make the best choices based on
Right.
drug utilization. Yeah.
Right.
Cool. Anything else? Any other questions? I think we're ready to finish up here. If you have any other questions, feel free to send me an email to len@dedicatedfinancialservices.com or go to that link, and you can put something in the comment section there that I will get a hold of, or schedule a phone call with Brady. And that's it. So someone said, thanks. My pleasure. My pleasure to serve you all. Have a wonderful rest of the day, and we'll look forward to being in touch with you all.
Appreciate it as well. Thank you, everybody, for your time. Lynn, thank you for allowing me to do this. Any questions, and just reach out to me, and hopefully we get some people on my calendar that want to talk Medicare.
Thank you, Brady, for your time.
Thank you.
Have a great rest of the day, folks. Take care.